Our group presentation is on EDMR, which is eye movement desensitization and reprocessing. And this is Megan, Maureen, Rose, and Margaret. All right. So what is EMDR? Go ahead to the next slide. All right. So EMDR is eye movement desensitization and reprocessing. It is a psychotherapy treatment that is designed to relieve distress associated with traumatic memories. During a session, a client will attend to an emotionally triggering event in brief sequential periods, while also focusing on an external stimulus. Most times, it's directed eye movement from side to side, but it could also be hand tapping or tones. The reasoning behind this type of therapy is it facilitates accessing traumatic memories, making the information processing enhanced, and then new associations can be created, and more adaptive information can be installed. The results are complete trauma memory processing, new learning, elimination of emotional distress, and development of cognitive insights. In EDMR, there are 8 phases of treatment. Each session, you would move through most of the phases depending on the session. For better context, here is what each phase is. If you look to the right, you will see a graphic that breaks down each phase. In phase 1, a therapist will assess clients' readiness, possible memories, or current situations that causes emotional distress, and also assessing the skills and behaviors that will be needed by the client. As a group, we got to talk to a friend of mine who is currently going through EDMR. In this stage, she was asked about her 10 worst days, and they worked through which days were important to process and what were her root traumas. In phase 2 is when a therapist will provide support in how the client will handle the emotional distress, such as teaching stress reduction techniques. These techniques will help them during and between sessions. For my friend, she learned meditation techniques, and she developed a relationship with her therapist to build up trust. Also, explaining to the client what they could experience is what the process looks like is a part of this phase. Phases 3 through 6 are when a client starts to process one of their identified events. They'll start by bringing forth a vivid visual image related to the memory by thinking of a negative belief about self and related emotions and bodily sensations. It's important that a client also identifies a positive belief before they're starting this process, because that positive belief will be important once the client finishes with processing. At this point, once the client identifies and brings forth the memory and really feels that memory, they will engage in the external stimuli using eye movements, taps, or tones, all bilaterally. Then the client is to notice whatever is happening within themselves. Once the client reports no distress while processing, they will then be asked to think of that positive belief. After processing, the client will then let their mind go blank and notice whatever thought, feeling, image, memory, or sensation that comes to mind. The therapist then takes whatever the client reports back and will choose what the next focus of attention would be in the following processing. Moving into phase 7, the client then takes time to return to a state of equilibrium and might be asked to keep track of the following week. So logging anything that might be related to what they've been processing. Also important when closing the session that the client is reminded about the techniques that they learned in phase 2 to help them cope with what later come up for them. Phase 8 is about examining and processing what has been made before starting back into a new session. This occurs at the beginning of the next session. And then I wanted to leave you with this quote that was found on the EDMR International Association website. So it says, EDMR therapy is not complete until attention has been brought to the past memories that are contributing to the problem, the present situations that are disturbing, and skills the clients may need for the future. So I thought that was a really good wrap up of what EDMR is.
Okay, I'm moving into history. The history of EMDR begins with a woman called Francine Shapiro. In the early 1980s, she was pursuing her PhD in literature when she received a diagnosis of breast cancer. She was treated successfully and then made a full recovery, but the experience led her to put aside her dissertation and change her focus to psychoimmunology, the effect of stress on immune function. And that was at the Professional School of Psychological Studies in San Diego. So one day in 1987, she took herself for a walk in a park, and as she walked, she found herself thinking about an emotionally distressing memory. She noticed the way her eyes flicked back and forth as she focused on this event, and then later when she recalled the same memory, she found it less distressing. She began to experiment with this connection and found that other people also experienced a decrease in the negative emotions around a traumatic memory. And the eye movements alone did not create comprehensive therapeutic effects, so Shapiro added a cognitive element and developed a standard treatment. This became the focus of her new dissertation. She conducted a case study and a controlled study to test the effectiveness of what would become EMDR. In the controlled study, she randomly assigned 22 individuals with traumatic memories to two conditions. So half received EMDR and half received the same therapeutic procedure with imagery and detailed description replacing the eye movements. Participants rated their distress around their memories before and after the treatment, and the participants in the EMDR condition reported a significantly larger change than those in the imagery condition. So Shapiro received her PhD in clinical psychology in 1988 and became licensed to practice in California. Her study was published in the 1989 Journal of Traumatic Stress, and she began training other clinicians around the country to perform eye movement therapy. There is a video on the next slide here of her. This is Francine Shapiro in 1989. So when it first arrived on the scene, EMDR made a significant impact, and it has been met with criticism over the years. Some of the critiques focus on how EMDR is conceptualized and disseminated. It was touted as a miracle cure when it first came out, and garnered a really devoted fan base. Sometimes in circles that's referred to as the Church of Shapiro. And so with any professional training, if a treatment is being described as sort of all you need to know as a practitioner, or changing therapy as we know it, anything kind of hyperbolic like that, it should be approached with some healthy skepticism. And we should be open to all evidence-based modalities, but it's probably best not to become too enamored with any of them. Another critique claims that EMDR is just exposure therapy under a new name, since it desensitizes people to traumatic memories. Bessel van der Kolk wrote that a more accurate way to think of EMDR is integrating traumatic material that had previously been experienced as sensations and images, as in PTSD, where the memory sort of remains stuck. Exposure therapy for PTSD works by having clients relive those traumatic memories repeatedly, and then they are gradually able to become less reactive. But as far as we know, it doesn't actually integrate the memory, and it doesn't help them with engagement or connections in their lives. EMDR focuses on regulating those intense memories, but also builds ownership over past experience, which allows people to access and process their trauma as events in their past, rather than just triggering moments. So because we don't have an exact understanding of the way EMDR works, it has also been dismissed in some circles as a pseudoscience. It's meant to work by changing the way the memory is stored in the brain, which reduces and eliminates the problematic symptoms. But how exactly are these neural pathways being reconfigured? The mechanism is unclear. That's also true of many antidepressants. In fact, in 2007, Bessel van der Kolk conducted a study comparing Prozac to EMDR using a placebo as a control. EMDR significantly outperformed both Prozac and the placebo, and he suggests that some of the skepticism may stem from the idea that EMDR is just too simple to work. Is it just CBT with some flashing lights? In 1999, there was a study done on veterans with PTSD, and they actually used EMDR as the control because the researchers expected it to perform so poorly. But what ended up happening was 12 sessions of EMDR turned out to be the more effective treatment. And now EMDR is one treatment recommended by the US Department of Veterans Affairs. Today, it is recognized as an evidence-based treatment. There are over 100,000 clinicians trained in EMDR, and it is conditionally recommended for trauma by the World Health Organization and the American Psychological Association.
Who is the treatment best suited for? Characteristics that are best suited for EMDR include patients with single trauma exposure and patients with defined traumatic experiences that they feel symptoms are sourced from, so something that they can pinpoint as a source of the symptoms they're experiencing. No co-occurring substance abuse, as that affects their ability to focus on things and their eye movement. And patients who are willing to invest the time commitment and understand that this is not a quick fix for them, but it's something that they really have to dedicate themselves to. Which mental health illnesses respond best? Adults with PTSD. I think EMDR is probably famous for its ability to help alleviate symptoms of PTSD, but it also helps with depression, single event trauma-related mental illnesses, and anxiety. So anything where a person can focus on a particular memory, that's when EMDR is really useful. Populations that might consider EMDR include children. There have been some studies involving kids with PTSD. One of those studies involves a group of children who experienced a car crash and displayed PTSD symptoms. 27 children aged 6 to 12 participated in a 4-session program for EMDR. Their results were compared to a 6-week waitlist group who had no treatment. The children in the treatment group showed significant improvements. While all children met at least 2 criteria for PTSD symptoms, only about 25% met the criteria after treatment, while 100% of the non-treatment group still displayed at least the 2 criteria. In another study, they had 33 6 to 16-year-old children with a DSM-4 diagnosis of PTSD. They were randomly assigned to 8 EMDR treatment sessions. The post-traumatic stress symptom scale for children was used to evaluate their symptoms and their outcomes. Age modifications were made for the kids. For example, kids that were 6 years old or around that age had trouble describing what they would like to think about. So instead, they described what they thought ought to have happened during the events that they focused on. EMDR also proved to be helpful as a pedagogic technique, allowing the children to explore their emotions and learn how to identify them in addition to lowering their PTSD symptoms. In a study with post-stroke victims with aphasia, which is the loss of inability to understand or express speech, EMDR was found effective in reducing depression symptoms. In a study by Lobrecht van Buren, adults with autism were monitored for symptoms of PTSD. They used the term adverse events instead of trauma events because it was a broader concept of negative or distressing events. Because ASD can be thought of as a different way of sense making, it is difficult to say what might be a traumatic event for someone with ASD, and thus they wouldn't be able to qualify for PTSD diagnosis because they wouldn't meet the criterion A regarding trauma. So with considering that, they use the term adverse events. In the study, EMDR was found to significantly reduce PTSD symptoms, psychological distress, and autistic features concerning social motivation and communication following EMDR therapy. Moreover, the participants experienced a significantly lower level of daily life impairment related to the traumatic events following EMDR therapy. These studies show that EMDR is beneficial in its ability to be adaptable to populations that normally wouldn't benefit from talk therapy, either because of cognitive or developmental levels.
How do you see using EMDR in practice? I'm going to talk about how you become trained in EMDR and what some of the limitations are that you may want to consider when using it in practice. First of all, to become an EMDR therapist, you have to undergo specific training. The EMDR International Association is the main accrediting body that certifies training materials, trainers, and therapists. In order to be eligible for training in EMDR, you must be a licensed mental health professional, a pre-licensed mental health professional. So like in Washington, have your associate license and be working on your hours for full licensure under supervision. Or you can be a graduate student if you have met certain conditions, like you've completed all your core academic coursework in your graduate program, you're in the internship phase, or you're under the supervision of a fully licensed mental health clinician. That's an and there. The three main components to the training. There's 20 instructional hours. Those include a history and overview of EMDR, the model, mechanisms, and methodology of EMDR, including specific training on the 8 phases that Megan talked about. Instruction also includes information about professional, legal, and ethical issues pertaining to EMDR. The second component is 20 supervised practicum hours. When you're doing your practicum hours, you have to have a certified EMDR specialist who can oversee your work, and they hold the liability for you during that time when you're in training. And then the last component is the 10 hours of consultation, and that's more of a peer-to-peer situation where you consult with others about your practice. Every training program will use this book that you see here to the right, that's the recognized book for EMDR International Association. Okay, EMDR in practice. Since EMDR clients are about to revisit some really difficult emotions on purpose, it's imperative that you establish a strong sense of trust through the therapeutic alliance before you start. This really depends a lot on the client's ability to learn the skills and the tools to self-soothe and to self-control, because they'll be going through potential disturbances. The amount of time that's needed for that really varies on the client. A typical EMDR session lasts about 60 to 90 minutes. How many sessions are needed really depends on how much trauma or stress-related situations the client has been in. More than 30 positive controlled outcome studies have been conducted on EMDR therapy. Some of the studies show that 84 to 90% of single trauma victims were no longer reporting post-traumatic stress disorder after only 3 90-minute sessions. So it can be really effective really quickly. Another study funded by HMO Kaiser Permanente found that 100% of single trauma victims and 77% of multiple trauma victims no longer were diagnosed with PTSD after only 6 50-minute sessions. So again, more evidence that this can be a really effective and efficient therapy. In one last study, 77% of combat veterans were free of PTSD in 12 sessions. There have been so much research on EMDR therapy that it's now recognized as an effective form of treatment for trauma and other disturbing experiences. Like Maureen said, by organizations such as the American Psychiatric Association, the World Health Organization, and the Department of Defense. So again, EMDR in practice, it has some risks and side effects, but these are generally temporary and tend to dissolve as treatment continues. Of course, if individuals experience these symptoms in between sessions, they should tell their therapist and come up with a plan to work on the new memories or symptoms. I thought that it was important to talk about the limitations or the considerations that we should use, especially since we're in the middle of a pandemic right now, and telehealth is the delivery format that we're using for most mental health services at this point. The EMDR International Association put out a statement at the beginning of COVID that said, at this time, the body of published research literature that provides a foundation of knowledge regarding the delivery of virtual EMDR therapy is limited. This gap in knowledge illuminates the need for research in this area. I think it's really important to just note that there isn't sufficient evidence that this is a viable option to do over telehealth, and there isn't evidence that it isn't either. There just needs to be more research on that. Like Megan mentioned, we spoke with one person who had begun EMDR before COVID, and her therapist had chosen not to continue that and work with just a different modality via telehealth. I spoke with one EMDR therapist who still offers this over telehealth, and she finds that it's really effective still with her clients. So we just need more research. And then one last point is that when we spoke with the person who had experienced EMDR as a client, she mentioned that she needed a lot of recovery time after a session, that it was really emotional. And of course, this is just an anecdotal situation here, but I think it's really important to consider how much time someone may need and how much room someone may need after a session to recover, and if that makes it a viable option for some patients. So if you're interested in more information, this is a really great video that summarizes our presentation. We're not going to show it because it's 9 minutes and 43 seconds, but if you want to see more information, here it is.
Okay, so we're gonna, we decided for our character, we decided Katniss Everdeen. So for her case study, when Katniss was 11, her father died due to a mining accident, leading her family to live in extreme poverty. The two ways that Katniss was able to get food to eat for her, or provide for her family, was to hunt outside of district boundaries and had that risk of getting caught and punished, or she had to put her name in the running to be tribute extra times to receive food. Also during that time, she was the main character of her house due to her mother's mental illness and just emotional shut out. And so she was also taking care of her younger sister. At the age of 16, Katniss volunteered for her sister's place in the 74th Hunger Games. The games are seen as a must to remember the uprising, where 26 tributes will face off against each other to the death. After volunteering for the games, Katniss was put into the arena where she had to fight for her life and the lives of others, eventually having to kill other tributes and also watch while others die, including her really good friend Rue.
Okay, sorry, it took me forever to figure out what I was doing. Okay, so Katniss's symptoms are recurrent distressing dreams, avoidance efforts to avoid distressing memories, feelings of detachment, the belief that no one can be trusted, outbursts of anger, and difficulty sleeping with troubling dreams. So the DSM cites the primary criteria for oh my God. So the essential feature of post-traumatic stress disorder, according to the DSM, is the development of these characteristic symptoms following exposure to one or more traumatic events. The directly experienced traumatic events include, but are not limited to, exposure to war, threatened or physical assault, childhood physical abuse, being incarceration as a prisoner of war, attack, torture. So any number of these things could have caused Katniss's post-traumatic stress disorder, but so any one of them, but the combination especially. So since Katniss meets diagnostic criteria A for post-traumatic stress disorder and B, presence of one or more of those symptoms listed on the left-hand side there, she fits the diagnosis for PTSD.
treatment for Katniss. We would want to focus on reducing distressing dreams, improving sleep, and increasing positive relationship efforts with family, and reducing her angry outbursts, helping her get a better understanding of her temper and being mindful of it. Clinician characteristics. A clinician for Katniss is someone who is willing to understand her struggles with trust and would be willing to put in the work to gain her trust. Someone who is willing to be straightforward with her, as this will help in relationship building. The intervention would be EMDR. She has experienced trauma and has a diagnosis of PTSD and has yet to fully process her traumas. She is able to pinpoint specific events that she can recall and focus on during her EMDR. Preparing her would include helping her understand coping skills that she could benefit from, like breathing techniques and also meditation. It may take some time before Katniss is ready because she does have a tough time trusting people. So it might be that she does some talk therapy first to help build that rapport, and then she would continue on with the EMDR. Some of the memories that she might focus on might include Rue's death. Rue was a good friend of hers and somebody that she tried to protect during the games. The experience of being hunted down by the victors, also killing 2 people in the first games, and her attempt at suicide. She could also focus on the memories around her father's death or even her mother's mental health issues that may have affected how she copes.
So continuing with the do a client map, the number of people in treatment, for now, Katniss is going to be doing treatment alone for EMDR. The timing, EMDR is typically 60 to 90 minutes and lasts anywhere from 6 to 12 sessions. Because of the extent of the trauma that Katniss has experienced, we recommend that 60-minute sessions twice a week for 60 weeks would be a good starting place, and then we'll reevaluate for next steps after that. Medication, we recommend that Katniss work with her primary care provider to see if medication can help her with sleep, which is difficult for her. Adjunct services, down the line, group therapy could be useful for her, or family therapy, and the prognosis is fair to good. Her history of traumatic events is long-standing and severe, but she's motivated and willing to put in the work.